Hello, everyone. My name is Jim Seberg, and I'm the Assistant Director for the Medical Cannabis Research Center at Drexel University. Today, we're happy to be joined by Dr. Stephen Dickinson, who is a 2023-2024 Pilot Study recipient for the Medical Cannabis Research Center. I'll pass it over to Dr. Dickinson and have him give him a brief introduction for this great presentation today.
Hi, everyone. My name is Stephen Dickinson. As Jim said, I am currently serving as a research project manager at the Urban Health Collaborative in the Dornsife School of Public Health at Drexel University. And today I'm here to present some findings from our pilot study titled Use of a National Retail Database to Describe Marijuana Dispensary Location and Equity. So funding for this project was primarily provided by the Medical Cannabis Research Center at Dornsife, which provided the funding for the pilot grant. But I also want to acknowledge the Mesa Neighborhoods 3 study, which provided the funding for the initial purchase of the data set that we used, as well as a lot of the analytic backwork to get our protocol up and running before we applied for this pilot grant. I'd also like to thank the study team, so Jana Hirsch, Lonnie Tab, Steve Francisco, and Rayana Yazdi for all the work that they did to help make this possible. So for this talk, I'll do some intro and background. I'll go through the aims of our project. We'll do some methods. I'll display the key findings, and then we'll have some time to discuss future directions and implications of our findings. So medicinal cannabis has been used for decades to treat symptoms associated with chronic disease and pain. Since medical legalization in 1996 in California, patients with certain chronic conditions have been able to procure medical cannabis to help with their symptoms. However, given the continued federal prohibition on cannabis, research into positive and negative health effects of cannabis has been limited, since federal funding for such studies is still prohibited. And as of right now, of course, all federal funding for research is currently on pause. With each individual state fielding their own legalization efforts for cannabis and their own sets of laws and regulations governing the sale of marijuana, there's a lot of geographic variability in the distribution of cannabis outlets nationally. This leads the research field into the effects of medical cannabis open to further study to determine the health and social impacts of legalized marijuana. So some previous research has demonstrated that access and density of various retail outlets influences health outcomes. So communities, for example, that have higher densities of neighborhood recreation facilities have seen higher levels of physical activity, and those with more walkable neighborhoods with healthier food environments have lower rates of obesity. Neighborhoods with higher access to alcohol and tobacco outlets have associated negative health outcomes associated with higher use of those substances. And while access to medical marijuana dispensaries was not found to influence the use of the drug in younger adults with medical marijuana recommendations from a physician, there seems to be a repeating pattern of low income and communities of color being targeted for a high density of dispensaries. A previous study was done in a single state. Additionally, there's evidence that use of marijuana can have some negative effects on physical, psychological, and emotional well-being, but also has several benefits for those people who have conditions that it can alleviate symptoms of. So if we want to ensure equitable access to medical cannabis for those with qualifying conditions, while also being mindful of marginalized communities being targeted for higher rates of substance use, we need to understand the patterns of where these outlets are going at a national scale. So this research project created the first nationwide longitudinal database of marijuana dispensaries geocoded to several geospatial levels. So this data set and the data sets produced as part of this study enable disparities in distributions research that has not been conducted before at a scale that has not been done before. Utilizing data derived from the National Establishment Time Series data set, we were able to understand patterns of distribution and access across the United States down to the census tract level. So the aims of this grant were to create a national longitudinal metric of access to marijuana dispensaries annually from 2013 to 2019 for a tract and county level data repository. We also sought to evaluate equity and disparities in the locations of dispensaries by racial composition, socioeconomic factors, and compare where cannabis dispensaries were being cited in relation to tobacco and alcohol outlets. We also had a third aim, which sought to validate our data set with state databases, but we ran into some problems doing that within the time frame, which I will discuss a little bit later. So a little bit about the data set that we used, called BEDIN, or Business Establishment Data Derived from NETS. NETS being yet another acronym, which is the National Establishment Time Series. This is a homegrown data set developed in the Urban Health Collaborative at Drexel University. BEDIN allows us to look at all US businesses from 1990 through 2022, which was the last release of the data set. This study used the 2020 release, which included businesses up until 2020. Within the BEDIN dataset, there are these standard industry classification codes, also known as SIC codes, one of which is the marijuana dispensary SIC code. This shows us where every single registered marijuana database from 1990 through 2022 has been located, when it opened, when it closed, if it moved from a location to location, things like that. A couple caveats about this data set. It does not differentiate within the data set between medical and adult use dispensaries or dispensaries that allow the sale of both. It also does not include delivery ranges. So if it is a delivery service that just has a warehouse but not a storefront, we don't have the delivery range of those services, just a single point on a map. And this also only includes businesses that have been listed exclusively as marijuana dispensaries. So smoke shops, head shops, anything that would be kind of in the gray market is not listed in this data set. So for our methods, for AIM 1, we sought to develop the database. So we geolocated all of the dispensaries from BEDIN into real geographic space using the Esri suite, ArcGIS, if you're familiar, to do so. We also matched dispensaries to socioeconomic characteristics from the US Census using the American Community Survey's 5-year estimates. And then we also developed kernel densities, so figuring out the average density, how many dispensaries are per square kilometer, per 10 kilometers or 50 kilometers. We also evaluated equity and disparities using statistical methods. So we did some conditionally autoregressive models and a Moran's I to examine spatial patterning related to socioeconomic factors. So this is essentially what we came up with. This is a map of all dispensaries in the BEDIN dataset from 2013 to 2019. These are the individual points. You can see some clustering visibly in states where there are more mature markets, such as California and Colorado. You see more than places that have less mature markets. This is what the density of our density of our dispensaries looks like, where darker colors indicate a higher density and the lighter greens indicate a lower density. So as part of this data set, we also created individual data sets for every state that had legalized in some way cannabis up until 2019. And so for every state, we have point data location of all the dispensaries from 2013 to 2019, as well as accounts. So of course, being in Pennsylvania, I wanted to show you what Pennsylvania looks like at that point. You can see in the table to the right, the count increasing as time goes on, as the market matures. And California, being a more mature market, you can also see that over this period of time, there's been some explosive growth in the number of dispensaries registered within the data set. So some of the descriptive patterns that we noticed when looking at the our results. There is a large urban-rural divide in the density of dispensaries, particularly in states without expanded legalization. So states that have medicinal only are especially prone to having dispensaries only in urban or densely urban areas. One of the exceptions to this being dispensaries on American Indian lands, places that would normally be categorized as rural or suburban have a higher density of dispensaries if they are American Indian lands. We also noticed that there are lots of dispensaries located on the borders of states, particularly those that are bordering states without legal cannabis. For example, there are a lot of dispensaries in far eastern Oregon, which borders Idaho, which has no legalization. And then we also found that the more mature the market, there are more dispensaries with a higher density. So the dispensary siting becomes denser and more populated the longer the market um, is allowed to exist, which also indicates that it continues to be a viable business, which would allow for more actors to enter into the field. So these aren't pretty, but these are our scatter plots of when we did comparisons between tobacco outlets, alcohol outlets, the education status of census tracts, and income. On the left here, you have alcohol and tobacco outlets. The graphs in the blue are for 2013, and the graphs in the green, or sorry, the charts in the green are for 2019, showing our correlations. As a result of this, we found that there were positive correlations between the location of alcohol and tobacco outlets with cannabis dispensaries in both 2013 and 2019, and that pattern only intensified as time went on. Census tracts that had higher level of educational attainment, as measured by high school diploma or greater, were less likely to have a cannabis dispensary located within them. And we did not find a correlation between median household income and the location of dispensaries. Again, dispensary locations are primarily clustered around and within urban areas, leaving many rural areas without access. So some of the barriers that we encountered as we were doing this study, first is a lack of data availability at state level registries. So as I noted earlier, we did have a third aim to this grant where we tried to validate our data that we had in the Bedin data set with data from state available registries. The nature of how states license and record their cannabis dispensary permits varies greatly and poses a lot of challenges when attempting to develop a comparison between our Bedin data and state databases. Most states only list dispensaries that are currently licensed and do not maintain easily accessible listings of previous dispensaries or when dispensaries were licensed or unlicensed in order to give us that comparison with our longitudinal data set. Again, this made AIM 3 very difficult because we were not able to produce a longitudinal data set in the time frame of the study to compare with our Bedin data set. With a longer time frame, it's certainly possible to contact states individually and request longitudinal data to verify the validity of what we find in our study. Unfortunately, NETS, which is again the data set that Bedin is derived from, soon after the finding of this project, discontinued and announced that they would not be producing additional data sets in any subsequent data set after the 2022 release. While a longitudinal data set of existing Bedin data utilizing NETS as a starting point were compiled as part of this pilot grant, pursuing NETS as a viable business data set to monitor the patterns moving forward is not viable. However, as part of many ongoing discussions at the Dornsife School of Public Health, researchers who are currently utilizing Bedin data are discussing alternative business data sets that could be used in place of NETS for future business level data related to cannabis dispensaries. So no fear, there is going to be a lot of opportunity for us to update this in the future. We just have to find a replacement data set. And then once that better alternative is decided upon, we'll be able to derive more updated and continuously updated data sets as part of this study. And finally, there were some potential inaccuracies of bed and data, and this is why we wanted to validate it with state registries. So NETS is reliant on business owners themselves correctly identifying that their business is registered with the proper SIC code. It's self-reported data. So when we mapped locations of dispensaries using bed and data, we noticed that there were a very small number, but still a couple of dispensaries located in states that do not have any legalized marijuana. And this is why in the future, as we move forward with this work, it'll be important to validate data sets with cross-checking them with state licensure information. So as part of this data set, we produced a point layer of cannabis dispensaries from 2013 to 2019. We also created kernel density rasters at 100 meter, 10 kilometer, and 50 kilometer ranges. And we also linked demographic data for each of these dispensaries to the census tracts in which they're located. And then we also completed kernel density rasters for tobacco and alcohol outlets for comparison. All of these data sets are housed at the Urban Health Collaborative in Dornsife here at Drexel. So some future directions that we're thinking of taking this work. Of course, we want to have an updated data set with an updated source. As many of you who are working in this space know, or maybe just anecdotally know, the number of dispensaries that have come online in the last 5-6 years has exploded nationally. And having access to more points of data will allow our conclusions to be even more accurate. We also want to explore the effects of legalization and expanded access. So we'd love to dive into the types of dispensary ownership structures. So be it a multi-state operator versus a small single proprietor, and how those dispensaries are sited and space. And we also want to examine the implications of expanded access and targeting areas with low access for medicinal marijuana purposes. And then again, we need to validate our business data that we have with state databases in order to make sure it is as accurate as possible. And that's what I got. So I'm open to questions and discussion.
Thank you very much, Stephen. This is a great start to this type of work. Couple of questions that I had. I know that we discussed kind of the rural gap. Were there any kind of areas for opportunity for dispensaries? I mean, certainly we're working on kind of a 2019 data set here, but anything interesting from your perspective as kind of a opportunity for small business where needs of the community are not being met?
Sure. I mean, something that I'm very interested in is accessibility. And if you live in a dense urban area, you're more likely to have access to public transit or a larger, and at this, as we found, a larger number of dispensaries. But if you live in a suburban area or a rural area, your only option for transit is car ownership, or some areas have very limited public transit. And then also because there is a limited market for dispensaries in places outside of cities, either you need to get yourself from where you live to a dispensary in a city, or rely on maybe someone who can pick it up for you and get access to you that way. So there's definitely a huge opportunity to leverage people who live outside of dense urban areas to participate, especially in medical cannabis markets. Especially in states like Pennsylvania, where if you look at the Pennsylvania map, there are only dispensaries located in places that are like a named city. So there's a wide open market there. Again, this is based on older data, so it'd be interesting to see if any of those gaps have closed in the last couple of years. But yeah.
And in terms of that trend of rural cannabis deserts, if you will, were there any states that kind of bucked that trend?
Yeah, so as I mentioned, when I mentioned American Indian lands, Oklahoma is a big standout in that area. They actually have a density that covers much of the state. Obviously, it's not as easy to get to as if you live in a city with a lot of dispensaries, but dispensaries operated on native lands are currently providing that access to people who live there. And obviously, those are unique circumstances, given that they have their own governorship models and such. But granting access to people who live in more rural communities is certainly possible and obviously is financially feasible because otherwise those businesses wouldn't be operating there.
Great. Yeah, definitely makes sense. And I think Oklahoma does have a fairly open licensing structure, even outside of the Indian territories as well. So definitely interesting to see that as well. And knowing that the nexus of this study was really kind of in comparison to alcohol and tobacco retailers, and certainly understanding how those industries have kind of disproportionately targeted marginalized communities. What was kind of like the most interesting finding for you in terms of looking at this?
Sure. I mean, so when we think about alcohol and tobacco, those are viewed as kind of like vice substances, right? They're not something that are generally desirable, which is also why marginalized communities have been targeted in order to boost their sales and to keep those businesses open. I did find it interesting that we're seeing a positive correlation with cannabis dispensaries, especially given how cannabis has to operate in the US at this point. So it's a cash-based business in which it is highly desirable, and obviously a lot of dispensaries implement a lot of security measures in order to protect themselves because it's a cash-based with a very valuable product. So I found it interesting that they're still being cited in places that still match the profile of tobacco and alcohol, which might speak to something like targeting for frequent users who are not necessarily like the intentions may not be as altruistic for those who are trying to provide access to medicinal cannabis. It's more of a let's repeat what we know sells in the past and just keep opening up in those same locations.
Yeah, it definitely makes sense in terms of location. Now, as Pennsylvania considers legalizing adult use cannabis, um, the border state issue seemed to be kind of the big issue. I know that you had mentioned that within your findings. Um, as other states around us develop, did you see any kind of trends of those popping up more frequently?
Yeah, so if I looked at like New Jersey, for example, and I did get it wasn't included in the findings of this one, but looking at a more updated data set, there are a lot of dispensaries right on the border between Pennsylvania and New Jersey, like right across the river from Philadelphia. And you see that all the time if you drive on 95 in Pennsylvania. There's lots of billboards advertising dispensaries right in New Jersey, no medical card required. So I think that is showing that, I mean, Pennsylvania tax money is probably going right across the river. And New Jersey and New York are getting those tax dollars that Pennsylvania could be getting. But if we're not legalizing adult use, then we're just letting that money just drive across the border. And I think that's also the case in a lot of other states too. Obviously, Pennsylvania has a medicinal market, which is great, but for states that have true prohibition on it, you also see in more unlikely locations dispensaries popping up in order to capitalize on that market and the interstate transit.
Yeah, that definitely makes a lot of sense. And certainly with the conversation around it, it seems to be something very common, as you pointed out, in Oregon. And revenue is revenue at the end of the day. Um, Now, I know that you talked about a little bit about the limitations and understanding that this data set is primarily with registered licensed businesses. So it doesn't include head shops, doesn't include kind of like places where you'd find gas station cannabis. Um, in terms of future directions for the work, what are your personal hopes in kind of taking a deeper dive into kind of the existing market that's out there, either for hemp derived products or kind of in comparing kind of the legal versus kind of gray area market with those kind of hemp shops?
Sure. I mean, so first I would love to just get an updated database of registered, excuse me, registered dispensaries. And then that'll allow us to do some comparisons amongst things like ownership models. Sorry. Ownership models. I know a lot of states have requirements of a certain percentage of licensure going to particularly Black communities or other communities that were harmed by the war on drugs. Seeing where, as markets mature, where those recipients of those licenses are choosing to locate their dispensaries. And then also just comparing that to larger corporate movers and seeing where they're choosing to put their dispensaries. I also think the effect of cannabis legislation would be another good thing for us to dive into, looking at whether or not legalization of full adult use is diversifies where you tend to locate your dispensaries, or if we're going to see those patterns continue to proliferate and just have more dispensaries. And yeah, I think looking at the relationships between ownership and then legalization would be good first steps. And then if I can find data sets that look at things like Delta 8 or other gray market alternatives and seeing where they're sold, it does become a lot more difficult to get those things, especially because they are gray market. They're not necessarily registered as such. And like some head shops only sell tobacco products. Some are also selling Delta 8 or other hemp derived things. So it'll be a little trickier, but that's certainly something because it's a market that still exists. And if you are pulling people away from a regulated, tested cannabis market into more gray space, either because it's cheaper or because it's easier for them to access. I think that's certainly something to take a look at, especially as we see reports of things like impurities getting into some of those more gray market products and the potential health outcomes from those too.
Yeah, definitely um, something to keep an eye on. Now, in terms of limitations for the study, certainly talk about the data set, certainly talk about kind of the time frame as we really are only talking about 2019 here. Um, and for those future directions, do you see that this could be a viable way to kind of grade states on their efficacy for access and equitability?
Yeah, for sure. If as the data set's able to be updated, and then as we continue to get updated census data, it's certainly something that could be a living, breathing data set. Because part of the reason why we wanted to develop this was to provide a starting point for researchers, either affiliated with MCRC or others who are interested in doing some of this disparities work or looking at where dispensaries are located. And if we have an ongoing database that is updated and provides all this information pre-linked, then that could enable some other analyses that I can't think of or I just don't have the time to do in the future, which would lead to more interesting papers. Because I think it's going to be difficult to continue to get federally funded work. The Trump administration has not necessarily been saying that they are willing to move forward with the Biden administration's work on descheduling cannabis, which means it's going to be hard to get federal funding for it. So if we can create a starting point here at Drexel, I think that would be great moving forward.
Yeah, for sure. Funding is always kind of the key when it comes down to it, talking to other researchers in the space. In terms of kind of expected findings, was there anything that surprised you in terms of this? I know kind of talking about The rural gap is something that probably isn't necessarily surprising to most people in the audience, given kind of the conversation around it. But in terms of kind of like the public health aspect of it, um, the association between either income or education, was there anything that really caught you off guard?
Yeah, not finding a statistically significant relationship between median household income and where dispensaries are located was um, certainly surprising to me. Because typically, if like education and whiteness are found, you'll also see income being something. And just like anecdotally, I think of the suburbs of Philadelphia, which tend to be very affluent, especially like on the main line. There are still lots of dispensaries being built there, and lots of access being provided there. So I think that's an interesting finding, and I think having more updated data will allow us to validate whether or not that's actually a pattern that holds true, or if that's just something that is just because it was an early market and a snapshot in a relatively young market nationally. Something that we could also do is look at these. So I did these analyses, and my analyst, Steve Francisco, did these analyses nationally. But if we dive into states individually, we might be able to find more explicit patterns and see, particularly if one state, depending on legalization or what have you, is more likely to be cited in richer, whiter communities or poorer, marginalized communities.
And that would probably be particularly poignant, especially looking at states that either allow municipalities to opt out of legalization or things of that nature.
Yeah, and having cross-checking the how licensure happens, so not just getting the actual licenses, but also seeing what the policy around where you can build a dispensary, where it can be located, would be something interesting to look into on more of a granular level within each state.
I did want to amplify a question from the chat. During the research you did, any one state program stand out as providing good, consistent data?
Sure. So we didn't, as part of the study, we did not look at we did not pull any data from states directly. This was all from this business data set and data derived from the business data set. So I don't have a great question about that, or response to that, but um, I'm sure that's going to be, well, when I was trying to do preliminary work, states that had their own cannabis regulatory agency tended to have more information readily available on their websites. And some states operate all of this through like their Department of Commerce. And those states were a lot more tight-lipped about their readily available data. It might be possible to get them for if we were to contact them, but in terms of just getting those data readily, it was a little more difficult.
Yeah, it definitely seems to be kind of along that line in terms of certain regulatory commissions and bureaucracies tend to be a little bit more sensitive with their data set. And certainly moving forward, are there any other aspects like in verifying with um, either a regulatory commission? So in Pennsylvania, it would be the Bureau of Medical Marijuana. New Jersey would be the CRC. Massachusetts would be the Cannabis Control Commission. Um, I know that we had talked about ownership. Are there any other aspects of data that you'd like to be able to see from organizations like that?
Sure. I mean, I think figuring out, especially in medical markets, figuring out who is um, utilizing product and utilizing legal dispensaries, especially if we think about equity and access to community, like lower income people, if they are viewing the legal market as something that's prohibitively expensive, and that means that they are in a gray or a black market area with, not tested, not verified product. Um, it'd be interesting to see who is utilizing it and looking at the demographics of medical card holders. Obviously, it's going to be a lot more difficult in adult use states to get customer profiles because the businesses would have those and it wouldn't be the states maintaining that. But for states that have medical, I think it would be interesting to see who is accessing medical cannabis with with what frequency, what like the reason why they have a medical card, and if there are patterns emerging between the reasons for using medical cannabis and how frequently or where they purchase it from. So if they are traveling long distances to get access to their product because they need it for their pain associated with HIV or cancer, that would be interesting to see compared to if people are using it for things like anxiety or sleep problems. It just the possibilities for that are huge.
Yeah, and that's definitely one of the benefits of our longitudinal registry study that we're running through the MCRC. Kind of a little tease to stay tuned for some upcoming. We're coming up on our kind of quota of 1,200 patients here on our end. So hopefully within the next year or so, we should be having a bunch more research coming out specifically in that regard. Um, as well, wanted to give a shout out as well to a couple of our upcoming speaker series as well too. We'll hopefully have some promotional materials coming out shortly as well. But talking to Kat Packer of the Drug Policy Alliance, talking about kind of some of those rescheduling nuances and kind of the misinformation around it, as well as Steph Shearer from Americans for Safe Access, talking about the new recommendation for a potential legislative solution for the Medical Cannabis and Cannabinoids Act that'll be coming up in March. But we kind of want to circle back to what you talked about in terms of like medical conditions. Certainly, what we're seeing a lot within our data set is very much anxiety and chronic pain being kind of like the two main drivers. You know that when in one of our past speaker series with Dashita Dawson, she talked about some internal research that they did in terms of reasons for accessing even the adult use program, as she was the cannabis manager of Portland, Oregon. And the top three reasons why people use within that program was sleep, pain, and anxiety. So even as we talk about kind of the differences between medical and adult use, it'll be definitely interesting to see the spatial analysis, see if we can't break it down between the two. But even as people still utilize adult use markets, it tends to be for a medical reason as well too, whether that's put at the forefront or what percentage of their use it breaks down as medical versus kind of more adult use recreational. Um, will definitely certainly need to be researched, but a lot of interesting aspects of this that are very complex, very nuanced, but also in its infancy as well too. Um, are there any particular outside of kind of what we had just talked about as it relates to trends, any kind of interesting studies or areas of research that you would like to see grow?
I think, I mean, cannabis research and part of why I know MCRC exists is because it's in its infancy because of the prohibition. So I think, I mean, my biggest interest in the field is in disparities and access to where to dispensaries and um, where we're seeing those patterns emerge because it is a relatively recent market, and in a lot of states, only in the last few years has it been legalized. And I know some states are working hard to try to rectify some of the wrongs of past drug policy. And I think trying to figure out where, thinking the policy angle, the how policy shapes where things are located and who is affected and who has access is something that I'm very interested in for myself. And unfortunately, I think there's going to be some animosity towards looking at that kind of research, especially when you are thinking about concepts like race and whatnot. So moving forward, though, it's going to be important because if we want to ensure that some of our past wrongs around drug policy are actually rectified, we need to prevent them from being the same marginalized communities from being exploited over and over again. And we have the opportunity to do so because it's a new, highly regulated industry.
And I always kind of get that comment from people talking about when alcohol prohibition was repealed and kind of thinking about why do we have all these weird laws, especially in Pennsylvania, around you can't buy hard liquor in grocery stores. Why do we have the state store model? It's because of conversations like this, and in terms of you can really kind of create a market from the ground up. If anyone has any other questions, please feel free to put them in the chat. I will ask one from the chat here. 1 second to get back to it. The PA data is relatively small sample, but did you look specifically at location trends? You mentioned kind of anecdotal info on Philly suburbs, which seem to go against tobacco or alcohol location trends, or compare a medical-only state, PA, versus the adult use states such as Washington, Oregon, California, to see how those location trends may differ.
Sure. Yeah. Thanks, Steve, for that question. That was not something that we did as part of this pilot study, but it is something that we have specifically cited that we want to look into in future research. Now that we have a base model dispensary map and database, we'll be able to look at how things, especially if we get more updated data over time, where we can see additional patterning, especially as I'm particularly interested in as legalization changes. So if we see a cut point between medicinal and adult use legalization, looking at how those spatial patternings change. And then also looking at those tobacco alcohol locations over that time too, seeing if there are differences as legalization shifts. Yeah, so it's something that's certainly possible with our data set, and it's something that we're considering looking at for future work.
Are there any aspects of the data set that are kind of particularly important to it that you'd kind of want to make sure that any future data set also contains, or was it a fairly kind of basic in terms of location, um, as well as kind of being a licensed shop?
Yeah, so I think both the locations are important, but also the matching that we did in terms of socioeconomic variables, and linking the two of them together is important. Because if you just have a map of where dispensaries are, then like weed maps already exists. But if you want to be able to use it for actual spatial analytics and things like policy analysis, you need to include additional variables like socioeconomic status of and racial components of the census tracts where they're located. And then also density allows you to kind of flatten the where these things are located. So you're not thinking of just, oh, my census tract has a dispensary, but the one next to me doesn't. It allows you to think about where things are located and more of like a range of where people have access to things. So you can see cities that have much more dense siting of dispensaries, and things like rural or suburban areas have lower density and therefore fewer opportunities to have lower opportunities for access to um, cannabis.
And it should also, I'm very interested, especially kind of seeing the continuation of this from 2019 to present day. We've had a lot of, for everyone who either is in the industry or um, has knowledge of the industry, have had a lot of developments in terms of access points, specifically within Pennsylvania. Um, I believe we've have over, I want to say 160, 170 different dispensary locations, maybe even over 180 dispensary locations. So it'll be very interesting to see kind of what those next steps are. And then as well in states like New York that have kind of these more robust social equity programs that have had their hiccups to start and kind of figuring out what that looks like. Hopefully, we can get some more information to kind of figure out what these trends look like and really kind of grade these programs based on efficacy and kind of comparing and contrasting kind of how these programs have been laid out. Um, but we're pretty close to on time here, so might as well just wrap it up. Thank you very much, Dr. Dickinson. Great presentation. Very excited to see the future of the work. As far as for next steps for everyone interested, um, February 20th, we'll be having a case study on cannabis hyperemesis syndrome with pharmacist Nick Eggers from Verano Zenleaf. As I also mentioned before, we'll be having Steph Shearer for Americans for Safe Access coming on March 4th. And then April 8th, we'll be having Kat Packer of the Drug Policy Alliance. And then in May, we'll have Tom Marcotte of UC San Diego talking about cannabis and driving, kind of a lead researcher within that field. Definitely want to say thank you, Dr. Dickinson. Thank you to the MCRC team and everyone else on your team who is in attendance today.
Thanks so much for having me.